Hello, good afternoon, everybody. My name is Professor Biwi. I am the clinical lead and consultant in palliative medicine here in Oxford, and also the National Clinical Director for Palliative and End-of-Life Care at NHS England and NHS Improvement. Welcome all to this first Centre for Personalised Medicine webinar for this academic year. The Centre for Personalised Medicine is a partnership between the Oxford University's Wellcome Centre for Human Genetics and St Anne's College. Its principal aim is to engage academics, clinicians, students, patient groups, and the public with the benefits and challenges of personalised medicine. The Centre runs events throughout the academic year, from small college-based lectures, seminars, and online webinars, through to conference series and public lectures. You can find further information about this on the Centre's websites, and it also includes a rich collection of recorded lectures. Today, we're delighted to welcome Dr. Charlotte Chamberlain as our speaker. She's a public health consultant and NIHR academic clinical lecturer in palliative medicine. She works half-time at the University of Bristol and half-time at St. Peter's Hospice in Bristol. Her research interests are in palliative care, cancer, and commissioning decision-making in publicly funded health systems. Her talk today is on the case for palliative care in surgery, the right treatment for the right patient at the right time. Welcome, Charlotte.
So thank you very much to the Centre for Personalised Medicine for having me. I think as a palliative care doctor, having the invitation to present about personalised medicine, probably every presenter has an existential crisis of, do I deliver personalised medicine? And then as a palliative care person, you go through your Kubler-Ross stages of grief, and there's definitely a bit of denial, definitely some bargaining, and then hopefully acceptance, excuse me, that what I'll be presenting is something that will be novel, interesting, and prompt discussion at the end about whether I have sold a compelling argument that palliative care is a personalised medicine. So what we'll be focusing on today is the case for palliative care in surgery in particular, and I hope that you enjoy it and don't feel the need to check your emails as we go. Okay, so the story that I'd like to tell today is based on my work following a session in January where we presented the idea of how palliative care interfaces with surgery, palliative surgery, what do all the definitions mean in January in Bristol. And I will also be presenting my proposed advanced fellowship application in palliative care in surgery, and finally talk a little bit about the Lancet value of death commission. And the strand that carries through the whole presentation is thinking both at a population level and an individual level about the choices that we make as clinicians and whether we are helping patients to make the decisions that are right for them. And that's the personalised thread, obviously. But at a population perspective, we're balancing potential overtreatment and undertreatment and really trying to get that balance right. My background, I think it's important just to explain, as Bea mentioned, that I qualified as a public health consultant in 2016. And certainly when I moved from public health, which people will be in public health familiar with something along these lines, into palliative care, it was met with a number of raised eyebrows. I don't need to explain to anyone what health protection looks like now. Clearly with the current pandemic we are familiar, but also there's health promotion and health intelligence. So what interested me particularly in public health was about this concept that from a population perspective, some things that we did, that thinking about making these population decisions, that actually my PhD coincided with the Choosing Wisely campaign that started in 2012, where medical specialists were asked about what procedures, what treatments, what diagnostic offer they gave to patients that may not actually be benefiting patients, bringing about what they valued. And so when I embarked on my PhD, it was around the Cancer Drugs Fund, which was a ring-fenced fund to pay for expensive systemic anti-cancer therapy. The vast majority were for incurable cancers. And what was interesting at the time was whether that in itself was fair and whether it was actually delivering what patients expected. Was it delivering that clinically meaningful benefit? I think the headlines show that we didn't really find it was. And I'm particularly fond of this quote from Atul Gawande, who is an American surgeon and New Yorker columnist and author of Being Mortal, Medicine and What Matters in the End, so generally a bit of a Renaissance man. And he said, if end-of-life discussions were an experimental drug, the FDA, which is the Food and Drug Administration, would approve it. So this certainly got me thinking, as part of my PhD as well, about the value that we attribute to pharmaceuticals, something that we can easily measure. And from a personalized medicine point of view, clearly molecular testing, genomic personalization of treatments is incredibly important. But do we sometimes miss out that one of the key interventions that we deliver is actually the communication in a consultation, and that is an intervention, and it should be personalized, and it's important, it's imperative in fact that we get it right. So is a palliative care approach a personalized medicine? And I'm hoping that I will at least raise the debate here about that. I feel that it may contribute to the delivery of the right treatment. It is a treatment in itself, and we need to work hard to make sure we're delivering it to the right patients at the right time. So looking at the definition of a personalized medicine, I'll spend most of the presentation talking about delivering the right treatment to the right patient at the right time, a phrase you'll become familiar with. But also within the definition is an understanding of the biology of health and disease and the impact of the treatment on trajectories. So the next slide is really the only slide where I just wanted to highlight that there is a piece of that puzzle within palliative care and its personalized approach. And this describes, by Looney et al., for those of you who are familiar with it, it's a common presentation theme, but these 4 different graphs illustrate the common disease trajectories for particular conditions in the dying phase. Now, B, as you can see, so on the y-axis you have function or capability of the patient, and then time on the x. And the terminal illness, for example, may be something like pancreatic cancer, where you may be very highly functioning, very well, and then have a rapid loss, a rapid deterioration in ability to death. Now, clearly, as treatments have evolved and the range of immunotherapies and systemic anti-cancer therapies now, sometimes some cancer conditions may look more like the organ failure graph in C, which was originally modeled on renal failure, where you have this dip, which is followed by almost a plateau or a gradual decline, followed by another dip, where you never actually return to your original baseline. And that continues again until death. And finally, D is demonstrating a very common cause of death now, which is frailty and dementia in older age, and really one that has causes challenges for prognostication, and one that traditionally I think palliative care have been less involved with than clearly the cancer pathway, which we're more familiar with. So I promised I'd talk a little bit about our event in January, and the first thing to say is it was a fantastic event, which was very multidisciplinary. So we invited surgeons from a number of different specialties, palliative care, physicians, geriatricians. It involved ethicists, economists, sociologists, and importantly also included patients and carers to try and navigate what does palliative surgery mean in the UK. It's not something that's very, there's very little literature about in the UK, even though there's burgeoning evidence from the US. And the first thing we had to address was palliative care and the stereotypes therein, and surgery and the stereotypes therein. So for some of you on the call, you'll be very familiar with the image on the left, these two portraits. So on the left, you see Dame Cicely Saunders, the founder of the modern hospice movement, who died in 2005. And on the right, that's John Hunter, who's a Scottish surgeon, arguably the sort of first archetype of modern surgical practice. And there's clearly a cultural tension if we follow our stereotypes, where palliative care are known to be empathetic, holistic, thinking about the person and their loved ones as a unit of care, whereas surgeons, incisive, rescue culture, cut out whatever the offending organ is, and perhaps at times forgetting that there's a whole person attached. So that may have a tension, but I'm hoping to demonstrate with this that actually palliative care as a term was in fact coined by a surgeon. So Balfour Mount is a Canadian urologist who came to England to study with Dame Cicely Saunders and then returned to Canada and found that hospice did not translate terribly well because that made everyone think of nursing homes, so coined palliative care as a phrase. So clearly the relationship is longer than people care to acknowledge, perhaps. So in January, we set out to first get some of the terminology right and think about palliative care in surgery, highlighting or demonstrating to surgeons that actually they had a significant role already in caring for patients in the last year of life. And 17% of surgical inpatients will die within 1 year. So that clearly they are already providing end-of-life care. And also that surgical inpatients are significantly less likely to access palliative care services, and those that do access it later than their medical counterparts. So there's obviously a gap here, and that has to do with the relationship between palliative care and surgery. We also talked about palliative surgery and what is a palliative surgery, and does that terminology mean anything to patients or to clinicians? And for instance, if you removed metastasis in a patient with colorectal cancer, what is the intention? Is that to prolong life, or is it to relieve distressing symptoms? And does it make a difference what the intent is, or is it about the shared understanding between the patient and the professional and whether it's meeting the patient's goals of care? So framing the discussions around palliative surgery, what we did agree to focus on over the day is that we're thinking about vulnerable populations who are at risk of death, which is in keeping with the definition of palliative care, that it's about life-limiting, life-threatening. This is vulnerable populations at risk of death. And also encapsulated that potentially there's growing evidence that there is non-beneficial treatment at the end of life. And this has been more studied in oncology with the use of chemotherapy in the last month of life, but increasingly, and we'll talk a bit more about this, that there's acknowledgement that some surgery may not be in the best interest of patients in that last month of life, or even more than the last month of life. And we've talked a little bit about equity and what does all of this mean. So here's an opening slide from Mr. Angus McNair, who is a colorectal consultant in Bristol, and I think it frames the discussions well. So I'm just going to go on to the next slide, please, just to talk about where we went with this. So Anna Boleyn is an associate professor at Columbia University and describes herself as a palliative surgeon. So the Americans have a slightly different system. There's about 200 in the country where they qualify as surgeons, and then they spend a year full-time dual qualifying in palliative care to become palliative surgeons. And so the interface that she describes, I think if I was going to draw this now, I would probably draw it differently, but this is as they see it in North America, that clearly there's a large overlap. Clearly there's a significant role for communication, prognostication, symptom management, but that we mustn't underestimate the importance of the ethical decision-making that goes on, the role of geriatricians, and thinking how the population that are undergoing surgery have changed. And of course that people change care settings, and those transitions are really very key. So Professor Rob Hinchcliffe, a vascular surgeon, presented on that day in January and just pointed out that the Vascular Society guidelines also describe that sometimes not operating is actually the most appropriate management option. And that's been recognized in the research aims, a consultation exercise suggesting that we need to do more to understand the role of palliation, the role of palliative care in patients with critical ischemia, where there's insufficient blood supply to particularly lower limbs, was the guidance. So when I alluded to the conversation that there is over-treatment at the end of life, it comes under a number of different headings. Is it aggressive care at the end of life, potentially inappropriate care, non-beneficial care, all these different terms, but there's an excellent systematic review that tried to summarize all the different measures of intensity of end-of-life care, so more non-judgmental term, and what did those mean, and did they include surgery? So I think a number of these wouldn't surprise anyone in terms of thinking about, are these potential measures for over-treatment or non-beneficial care at the end of life? So number of hospital admissions, emergency admissions, length of admissions, ICU admissions, a number of things, CPR, feeding tube placement, chemotherapy, as I mentioned earlier. And down at the bottom of that list, there's life-prolonging treatments and surgical interventions. Now, I think whether they belong under the life-prolonging, I think is an area for discussion, but clearly they are being listed as something that occurs in the end of life and needs further research to understand whether or not that intensity of end-of-life care is bringing the desired benefit to patients. So this is an excellent slide from Philip Broad, who's a consultant geriatrician in Bristol, and I've just slightly adapted it, but it's actually from JAMA in 2019, and really as a geriatrician, he was talking about, are we asking the right questions and thinking about older adults? So for instance, rather than talking about the risks and benefits of a procedure, should we be talking about, will surgery prolong my life? How will it affect my quality of life? How does it affect my independence? And so in order to determine the right treatment for the right patient at the right time, we quite clearly, in my mind, need to ask the right questions and listen to the answers. And finally, another presenter from the day was Professor Richard Sullivan, who's a cancer professor at King's, and he was part of these global surgical commissions for the Lancet and Lancet Oncology, considering what is happening with surgery globally. And the take-home message is there's not enough of safe, timely access to surgery. Therefore, there's actually a significant amount of palliative surgery, because it's, by the time somebody presents, the procedure is unfortunately not curable. But the key message that he also had was that palliative surgery just isn't very sexy. You can sell buying a robot, that's definitely something funders are interested in, but trying to sell a structured conversation as an intervention can be a slightly harder sell. So again, our own bias that we need to be aware of as clinicians, as academics, as policymakers, is that are we biased towards pharmaceuticals and the next shiny thing, rather than getting the basics, the communication side, really perfect? So I've told you a little bit about that Bristol meeting that was almost, I guess, the start of the journey. And now I'm going to tell you about a little bit about where we've gone since, and move on to what the Advanced Fellowship might look like, before giving you some highlights for the recommendations of the Lancet Commission that's about to be submitted. The work that we've done since is really understanding more about the perioperative pathway, and that's learning from the Centre for Perioperative Care, who've got some excellent resources and published some really great rapid reviews this year, looking at, for instance, the role of the multidisciplinary team, the role of integrated care pathways in the perioperative period in order to improve patient satisfaction, symptom control, and improving the critical shared decision-making so that patients understand the risks and benefits of the procedure and why they may be having the procedure. And while that may sound simple, I'll show you a few papers that demonstrate that actually we're not always getting that right. So we did have this on the day, but it always bears repeating that in a study of Medicare beneficiaries, 1/3 undergo an inpatient surgical procedure in the last year of life, and nearly 1 in 5 had a procedure in their last month. So clearly there are questions about the procedures, particularly in the last month. Were they all to relieve distressing symptoms? Were they all understood by patients to be improving their quality of care? And obviously sometimes it's harder to predict that end of life period. It's great in hindsight, much harder to know without that. But it does raise questions about the intensity of care at the end of life, which is also, of course, very expensive. So clearly what we've demonstrated so far is that surgeons have a significant role in the end of life period. Their patients access palliative care less and they access it later. And shared decision making perioperatively we'll talk a bit more about, but there's room for improvement there. So how do we utilize palliative care and surgery together to deliver more personalized care? And this was just a reminder to me to mention that clearly no discussion about surgery in the modern day would be complete without thinking about how the patients that we are operating on differ to how they have in the past. So in particular, patients are older and they have more medical conditions. On the Y, there's survival probability, and just looking very broadly, the top 2 lines are those that are non-multi-morbid, they don't have multiple medical conditions, and the lower 2 lines are those with multiple medical conditions. And whether you're in a high volume centre or a low volume centre, clearly your survival probability is very much worse if you have multiple medical conditions, which probably isn't surprising, but certainly should influence our thinking and the complexity of the decision-making around surgery going forwards, and extrapolating results from a randomized controlled trial of a surgery to the populations that actually receive it in the real world. There are a number of articles that demonstrate that shared decision-making, consultations where we are trying to map the patient's goals to the treatment options are impaired. Either the patient may not understand the prognosis, the patient may not understand the procedure that they're undergoing, and they certainly may not understand the risks and benefits. So there are quite a number of studies going back a number of years, but these are just some recent good examples that have demonstrated that there is work to be done to optimize that individual level decision making around having procedures that may be high risk. And so bringing it back to the palliative care side of things, in 2014, a system-wide frailty screening approach was introduced in a single center in Nebraska. And following this frailty screening, they had noticed that it was creating an increase in palliative care referrals. And they wondered how the palliative care consultations, the frailty screening, what was the impact on mortality as a result? And it did find that there was a decreased mortality for those that had these 2 interventions, so co-interventions. And it's difficult to unpick the 2. The authors do make an attempt and put weight behind the palliative care, but I think it's difficult to see, but they're clearly interacting and they're clearly having an impact on mortality, which isn't obviously normally the aim of palliative care, particularly to extend life, but certainly to improve the quality of life until the end. So that's the first piece of evidence. And the next is a receipt of perioperative palliative care consultation has also been associated with better overall end-of-life care communication and support when families of patients who died were questioned. And so those were patients that underwent high-risk surgery. They weren't necessarily people who were on an end-of-life pathway per se, but they were high-risk surgery. And of the ones who died, those who had received perioperative palliative care, the families reported much better experiences. So we've already mentioned that unequal access to palliative care for surgical patients. but just in case you were looking for the source, this is the paper. And even when you adjust for medical comorbidities, it's very difficult to match medical patients with surgical patients to get a true estimate, but there does appear to be good evidence that surgical patients are getting less and later access to palliative care. So here's just an illustration, back of the envelope for me, about palliative care and surgical integration in the UK in current practice. Almost, it's potentially slightly ignoring COVID at this point. So a person is diagnosed with a life-threatening, for instance, an abdominal aortic aneurysm or a life-limiting illness. They may be referred for surgery. They could be seen as an outpatient or an inpatient, and they may receive a pre-operative frailty assessment, a comprehensive geriatric assessment. They may or may not participate in a prehabilitation program, for instance, about smoking cessation, optimizing their condition before undergoing surgery. And they may undergo surgery, or they may not be offered surgery because their risk profile or even their decision making means that that wouldn't be the right choice for them. Now, at no point in that pathway is there an automatic trigger for palliative care. And I think that still comes as a surprise to a number of clinicians, that even where no surgery is recommended and the patient is referred back to their GP, there still isn't an automatic trigger for palliative care, despite recognizing that they have a life-limiting illness or a life-threatening illness and frailty that means an operation would not be possible. And for those who do undergo surgery, again, there's no palliative care support for those who are undergoing high-risk surgery. On the other side of the algorithm, you have surgical inpatients who may develop symptoms that are consistent with dying, and that would certainly trigger a palliative care referral in most places. What we do know is that it doesn't trigger it early enough, and that it doesn't always trigger it. But it is a triggered consultation. The reason I labour that is on conversations with Associate Professor Anna Berlin in Columbia, the Americans have been looking at the consultative, and they call, asking for a palliative care consult versus the integrated model. And there's a growing movement to have palliative care not invited in at the point of symptoms, but as part of the multidisciplinary team, for instance, on a surgical ICU, to improve that interdisciplinary working and therefore improve the perioperative pathway. Now, this slide may be familiar to a number of you, and it's just adapted for the surgical setting, where it's the bow tie model, for those of you who've come across it, and originally devised in oncology. But putting it in the surgical setting, you can continue to have interventions, operations, disease-targeted treatment, but there's increasing recognition that it may be appropriate to invite palliative care in earlier in order to address the pain, physical, psychosocial symptom support that's required, and then there's that sustained care. So here's a different example of an integrated surgical palliative care, perhaps an ideal world where you have early pre-operative palliative care, post-operative palliative care, palliative surgical ICU continuity in that integrated model. It's sustained because palliative care continues to follow you in the community, and palliative care at the end of life. I think any palliative care physician on the call may be guffawing about where the resources are for this. So I think this is, an idealized example of integrated working with palliative care and surgery, and the practicalities are something we need to discuss. And what's interesting, and I will be talking about the difference between palliative care and supportive care in brief, but there are, to my knowledge, only 2 trials underway at the moment in the world that are looking at perioperative palliative care. There's a multi-center, this Periop PC on the left, and a single center randomized trial, scope trial on the right, and both are looking at the value of perioperative palliative care to provide, as we discussed, particularly focusing on some of the shared decision-making, advanced care planning, and managing both the patient and their loved ones through their journey, and addressing as well their physical and psychosocial symptoms. But for me, the question in the UK is that we have a different model. While those 2 trials are underway, I'm still not clear on what the essential ingredients are of a perioperative palliative care approach. As I mentioned before, the Centre for Perioperative Care have some great rapid reviews that have looked at the importance of multidisciplinary working and integrated working. But what's clear from those reviews is that those integrated pathways are not universal by any stretch, and that they are done very differently. And we're still not clear on which parts of the model are bringing the most benefit to patients and how to replicate that and scale it up so that all patients have access to a streamlined, supported service that meets their goals. So here's the hopefully novel bit. This is the part of the advanced fellowship application. So what I'd be proposing is a feasibility study. That would be the final part of a 5-year program to establish a main trial of perioperative supportive care in patients undergoing major cancer and vascular surgery. So major surgeries, but not exclusive to cancer, as in the 2 existing trials in the US. Whether that's possible, measuring global quality of life. And partly, I'm sure that vascular surgery, and I'll show more, has very poor outcomes when we're talking about peripheral vascular disease in patients with diabetes who undergo lower limb amputation. The reason we chose those populations was partly based on this Jane Mayer paper, which really makes it very clear when you look at that third group at the bottom there about the shorter term survival, that based on population data, clearly the survival rate for patients with these cancers, 1-year and 5-year survivals, despite the treatment options we have available, are still very poor. And so even those that undergo an esophagectomy, less than half will be alive at 5 years. And at 2 years, the mortality is severe as well. And 1 year, as you can see here. So I think that's an obvious reason to choose that cancer population. But as I said, clearly there are also significant reasons to consider populations without cancer, where we know palliative care traditionally see less of these populations without malignant disease, and yet the outcomes, here you can see Professor Rob Hinchcliffe pulled this graph together looking at major amputations in patients and their 5-year survival rates compared with other 5-year cancer survival rates. You can see they are really very poor and close to stomach cancer. So we've talked about a population, and the populations I'm proposing will certainly be those who are undergoing high-risk resections, be they for cancer or, for instance, in vascular disease. The intervention, as I've written here, is about perioperative supportive care. Now, the reason to change the term from palliative care to supportive care, which is not in keeping with the American studies, is based on stakeholder engagement with our surgeons who find the term palliative off-putting, I think it would be fair to say, and that it would discourage recruitment to the study and hinder patient care. Now, I think that's certainly something we can discuss at the end and consider the differences between supportive and palliative care. There is considerable overlap. Both address the physical and psychosocial symptoms and address a more, or aim to work in a very holistic way. Supportive care traditionally was defined and came out of cancer care alongside potentially curative treatment for cancer. And this would be a comparison against standard perioperative care. And as I highlighted earlier, with those rapid reviews, it's clear that standard care is not standard, it is variable. And so that throws another interesting dimension to the work. And the outcomes, obviously, of the feasibility study will be to see whether randomization, recruitment, outcome assessment can all be measured, including some healthcare utilization measures. But the aim in a larger trial would be to consider global quality of life and how having a perioperative supported approach that works within the multidisciplinary and integrated pathways suggested by the Perioperative Centre for Care, whether that is a different model that improves patient outcomes. Basically, the only takeaway from this slide is that the proposed advanced fellowship 3 work packages as is traditional, but that really the first 31 months is all about designing the intervention, because what's clear is that it isn't clear what is the essential ingredient that improves perioperative care. And while we can point to multidisciplinary work in integrated care, when we're thinking about high-risk surgery, there's clearly more to be defined to structure that intervention that will be central around communication, shared decision-making, advanced care planning, physical and psychosocial symptom control, understanding really what the intervention looks like, and then following that through the feasibility study with process evaluation will be absolutely critical. And so the end of the work would complete with the feasibility study. So stay tuned, and my hope is obviously that this will help define what the right treatment is, which clearly I believe adding a palliative care component will help personalize the treatment pathway of perioperative care. But also we need that interdisciplinary work to ensure that we're delivering it to the right people at the right time. I hope to use the last 10 minutes to talk about the Lancet Commission on the Value of Death. And rather than it feel like an add-on, just to say we started this work 2 years ago, and I've been privileged to be part of the group exploring the relationship of medicine to death, and whether as a society our relationship to death is influencing the care that we receive. There was an absolutely fantastic Lancet Commission on alleviating the access abyss in palliative care and pain relief, that made a very compelling argument about the lack of access to opioids to relieve distressing symptoms, so the undertreatment globally for end-of-life care. And our commission was given a different brief. So while we felt that undertreatment had been really very well elucidated by this work, the question that was being raised was actually, is there this element of over-treatment where we've lost our familiarity with death as a society? It is something that we fear, both as health professionals and more widely, and therefore some of the decision-making, because we'd lost that relationship with death, was distorting the value and distorting our decision-making. So that was our brief, which was not an easy one at times. But really we wanted to ensure that while the under access to palliative care as a service and opioids is critical and important, and we want to recognise all the improvements in life expectancy, we still need to acknowledge that both at an individual level and at a population level, some of the decision making where medical expenses are the leading cause of personal bankruptcy in countries like the US, really addressing how that decision making happens. And even in the UK, where we as a society agree to spend more on medicines at the end of life than we spend on other medication according to NICE thresholds, then we need to be more open and explicit about our debates and the opportunity cost therein about what we are signing up for. So you wouldn't be surprised that a public health consultant would be keen to get in the Dahlgren and Whitehead social determinants diagram, but what we realized was that the social determinants of health are also the social determinants of dying well. And so thinking exclusively about healthcare services was not going to address the disconnect between dying and society's relationship with dying and facilitating people to live well till the end. So here's one of the quotes from: "An even more horrible death is one that's kept at bay by the miracles of modern medicine, a death that never ends. In the name of Hippocrates, doctors have invented the most exquisite form of torture ever known to man, survival." So we looked at Becker, who's a psychoanalyst and anthropologist, who found that briefly exposing health professionals to thoughts of their own death may make them advise more aggressive treatments for their dying patients. And in contrast, longer courses on death and dying, as experienced by palliative care clinicians, may make them advise less aggressive treatments. So clearly we need to, again, acknowledge our own biases, our own relationships and fears with death in order to explore that we are orienting our treatment options towards what is important to patients. And that includes understanding their fears of being a burden, their goals for what they hope to achieve in the remainder of their lives. So some of the recommendations from the report briefly in the last few minutes about revaluing and rebalancing death and dying. And I think public education on death and dying must surely have been a recommendation in every policy report for the last probably 10 to 20 years. And we still are failing to implement it. But public literacy on death and dying, greater public awareness, greater debate is clearly something that's important to make sure that we're making the right decisions as health professionals, as commissioners, as policymakers. And acknowledging the opportunity cost that all countries with universal healthcare need to be aware that spending money on treatments to extend life, and bearing in mind that most of the money we spend is in the last year of life, that means not spending it elsewhere. So it may not be spending it on palliative care to relieve suffering, for instance. So our local hospice is only 19% NHS funded, and the remainder is from charity, which during the time of the pandemic, without collecting tins and events, is clearly a significant challenge that we need to address. And I've just commented here about metrics that we really need to measure and measure again, that if this slide talks about the variation in the proportion of people who have 3 or more emergency hospital admissions in the last 90 days of life by CCG, so a marker of intensity of end-of-life care, potential overtreatment. And if we're not measuring meaningful outcomes for patients, then we won't come up with the right answers. So it's about asking the right questions. One of the other recommendations I'm very pleased to say in the time we've been making the report, there has been progress in. So we're not the first commission to have come up with a recommendation similar to this, that compassionate leave in the period approaching or following the death of a loved one should be a statutory right, mirroring the rights granted for parental leave in many countries. And actually in the UK, it wasn't a statutory right. It was generally 3 to 5 days, which was accepted, but not statutory. And this year there has been a change in policy so that those who have a child under 18 die are now permitted 2 weeks of statutory paid compassionate leave. Now, that only addresses obviously those that lose a child. I think there is a long way to go, and it doesn't address the gendered nature of care around the end of life, which is a very significant issue, and something that's addressed in the Commission in terms of the power imbalance that's worth having a read. Really pertinent, obviously, to this talk about palliative surgery is the recommendation that the responsibility for dying well should fall neither to health services nor communities, and that this is a partnership approach involving shared power, shared decision-making, and co-design of services to enable people to die well. Now, in the palliative surgery approach, as part of the fellowship, I'd be looking at co-production, which means involving patients and carers from the very beginning in order to help design the interventions that are meaningful for them. And the COVID pandemic, there are reports that have been released demonstrating that PPI, public and patient engagement, has reduced. It is more challenging, but it's clearly something that we still need to continue to emphasize. And I'm happy to talk about compassionate communities and other community approaches to get that shared power right, if people are interested at the end. So again, really, this is the crux of the palliative surgery, that one of the recommendations is about palliative patients and families should be provided with clear information about the uncertainties as well as the potential benefits, risks and harms of interventions in potentially life-limiting illness. That top image is from Taylor et al. It's about the best case, worst case scenario. It's a really lovely YouTube video if you're interested in this sort of thing. They've even done some work where they looked at whether showing a shared decision-making video perioperatively, actually pre-operatively, whether that improved outcomes. And they didn't find it did, but it's a really interesting paradigm about how do we improve the communication because we think we may have told someone all the critical information in order to enable their decision, and actually when you do a post-consultation survey or interview, then you find that the understanding on both sides is quite different. And Atul Gawande's Serious Illness Conversation Guide, again, to improve the level of our communication, which in itself, as I said, is an intervention. Overtreatment and undertreatment, and palliative care and surgery as a personalised medicine. I hope that some of the evidence I've presented here demonstrates that palliative care, supportive care, conversation is an intervention in itself, and it is a personalised medicine. Defining how we deliver that medicine, that right treatment, is critical, and who we give it to and at what time is clearly still all up for grabs about what makes this the right treatment. So to end with an Atul Gawande quote, of course, our ultimate goal after all is not a good death, but a good life to the very end. So these are some of my details, and while we won't be putting the whole slide set up until I've submitted the fellowship application, I'd be very happy to be contacted if anyone had any questions or anything they wanted to discuss in the future.
That's great, Charlotte. Thank you very much. That was a really interesting walk through all those aspects, and I'm sure it's left people with lots of food for thought. And we do have a few minutes for questions. Can I kick you off with one from Simon? Does a culture of palliative surgery in the US encourage surgeons with more patient-minded psyche into the specialty, do you think?
That's a really good question. And so I was lucky enough to be awarded a Churchill Fellowship at the beginning of the year to look at the culture in palliative surgery. And I'd been particularly wondering about how the US model was evolving quite differently from our own. And there are a number of female palliative surgeons. Is there a gender bias, as you say? Is it attracting different people to do that certificate to change the face of surgery? And the answer is, I don't know, and I haven't seen any literature about it, but I think it's a really interesting question. And I think it warrants more investigation.
Okay, and from Porrick, Dixon says, thanks for a great talk. 2 questions, please. We'll start with the first one anyway and see how we get on. Is much known about how the costs of surgical interventions compare to other non-surgical palliative interventions?
So not enough, I think, is the answer. And just to give an example, for instance, if someone had a cervical cancer or a colorectal or prostate malignancy and it becomes very large in their abdomen, it can block off the urinary tract. So their kidneys will fail. It's a malignant uropathic obstruction. The kidneys fail, and the current treatments, depending on where you are in the country, are either to put in a stent to allow the wee to pass from the kidney into the bladder and out, or to insert a tube through the skin so that the urine can drain out that way from the kidney. Now, there are some trials where they compare those 2 approaches, but when you talk to urologists, what they really want to know, a number of them, are what happens if we don't do either? Because they're not actually convinced that by de-obstructing, if that's a word, by facilitating the flow of urine and allowing an extra chemotherapy course, does that really prolong their life? Does it really improve their deliver what the patient is hoping for in terms of quality of life? And so the problem is trying to cost the non-disease targeted treatment isn't being studied. So you can see a comparison of the stent versus the percutaneous intervention, but what you don't see is what happens if we do neither, both for cost and for quality of life. So that's just one illustration, but there are others where I think there's a significant amount of work to be done.
And in a way that leads very nicely into the next question, which is around what kind of instruments you think you might use to measure the quality of life in your feasibility trial.
Now that's a can of worms, Park. So there's so clearly, you know, we could follow the EQ5D and the Europal and the more traditional instruments. There's also a capability approach, which there's an argument that using traditional quality of life assessments at the end of life don't accurately capture the change in quality of life, and therefore costing using those usual measures is, I think it would be fair to say, inaccurate, whether it's an under or an overestimate, but it's certainly inaccurate. So there are new approaches, including the ICE cap measure for palliative care. And to be honest, I'm undecided and looking for a health economist who would be interested in investigating this with me if I'm successful in the fellowship to pursue about how do we better demonstrate, because I think cost is a critical part of the population health palliative discussion, where so much of our expenditure is in the last year of life. And is that what the population want? Are we spending it in the way that the population want? And actually asking people, when we look at, there is a systematic review that looks at how we value death as a population, and it doesn't necessarily say we want to spend more on life prolongation. So I think there's clearly work to be done about that transparent conversation about how we value death and what we spend on it.
The subject of whole other dissertation, isn't it,
yes.
Charlotte?
I don't know is the answer.
So in the last minute or so, I'm just going to, this is a question from Simon, but I'm going to use Chair's prerogative to modify it a little bit. I think we could not finish a session in these times without reference to COVID-19. To what extent do you think the exposure to death and dying through COVID-19 might influence hospital doctors, particularly trainee doctors and medical students, to, I guess, embracing the concept of palliation and palliative surgery, perhaps?
So that's such an interesting question. And actually, as a commission for the Lancet Commission, when we started this pre-pandemic, we have been continuing it during the pandemic. And at the start of the pandemic, a lot of the commissioners were saying, obviously this is dreadful, but perhaps it will raise the debate about putting people understanding that death is an inevitability, as much as we don't like to think about it as such, but that understanding the importance of death, being surrounded by your loved ones and how significant that is, that should shape the discourse. And instead, what we saw evolve was a conversation about ventilators and the importance of funding more beds, rather than actually prioritizing what do people want. And then the advanced care planning, where it was done poorly and systematically rather than individualized and tailored. So I think what I worry about is the pandemic has heightened people's fear of death rather than learning the value and appreciating the benefits of being with your loved ones, and how do we facilitate that, and thinking about some of the more, well, the very important measures. I think the other important take home I've had from the pandemic is about the moral distress amongst health professionals, and as part of that, that's supporting patients who are dying, for health professionals who don't normally feel they're in that position, about the potential triage at the beginning in that first wave, and whether we'll face that again. And so that moral distress faced by health professionals, again, I think palliative care have a very important role, and it's part of that perioperative pathway as well. It is the multidisciplinarity that allows reflection and consultation, and that should be the norm, rather than a single individual feeling that they've made a life and death decision that doesn't sit easy. I think I think from that point of view, that's certainly a clinical takeaway message for me, and one that I hope that we can research more. But do I think that the level of conversation has changed in the direction that I hoped, that there would be an understanding of the importance and the value of relief of suffering and being surrounded by your loved ones, and that value? I'm not convinced. Maybe I'm being pessimistic, but I'm not convinced the take-home message that the population has.
Okay, thank you, Charlotte. Thank you, everybody. I know there's a couple more questions, but I think we've time now. So I'd like to thank you, Charlotte, for this really excellent and thought-provoking session. And I'm sure that will leave everybody going away thinking some more about that whole range of the role of perioperative and palliative surgery in serving the cause of personalized medicine and personalized care, and also thinking about COVID and the essential nature of a personalized approach, whatever the situation that we're in. So thank you all very much, and thank you everybody for attending.